The RPA PAL program is sponsored by an educational grant from Amgen, and we appreciate their support. Finally, be sure to check out the RPA website for upcoming webinars and events, as well as our COVID hub. I will now turn this over to our moderator, Dr. Weisberg.
Good afternoon, everybody. Thanks for joining us. We have a distinguished panel to talk about home dialysis, and I'm sure everybody who's on is very interested to hear what they have to say. Let me introduce the panelists first, and then I'll give a brief introduction to the session. I want to introduce Samaya Anamudu. She is Assistant Professor of Medicine and Nephrology at Baylor College of Medicine in Houston, Texas. And let me say right now that we are very sympathetic to the surge of COVID that you're undergoing there in your community, and we wish you all the best. Dr. Anamudu serves as the Vice Chair of the RPA Government Affairs Committee and is also a member of the RPA Education Committee. She's a junior faculty intern on the American Society of Nephrology Policy and Advocacy Committee. Arvind Garg has joined us. He trained in nephrology at Washington University, St. Louis. Let me say that there is a very deep Washington University, St. Louis connection on this panel. He's been in private practice since 2014 with Springfield Clinic in Springfield, Illinois, where he is the medical director of Fresenius Home Dialysis Unit. He's a member of the RPA PAL Steering Committee. Harry Giles, you've already met. He received his undergraduate degree in religion from Birmingham Southern College, so you can believe everything Harry says. He completed his fellowship in nephrology at Washington University, St. Louis. He's a member of the board of directors of the RPA and is chair of the RPA PAL. Brent Miller is the Michael Krause Clinical Professor of Medicine at Indiana University and the Kidney Service Line leader for Indiana University Health Physicians. Dr. Miller was a professor of medicine at Washington University, St. Louis, where he was the medical director of home dialysis modalities. He's been an investigator in many home dialysis trials and is a consultant for the home dialysis with Fresenius Kidney Care. He's been active in home dialysis education initiatives such as the Home Dialysis University, Advanced Renal Education Program, and the American Society of Nephrology online home dialysis curriculum. By way of full disclosure, I should say that I got my undergraduate degree at Washington University, St. Louis many years ago. So let me just say that for those of you who were on the previous session, you know that all the value-based care models that that CMS has proposed and that many of us have placed applications for, put a tremendous emphasis on home dialysis. The idea is that home dialysis is the modality of not just the present, but the future in a very big way. Most people agree that home dialysis offers patients lots of personal autonomy. It's improved quality of life. There's preserved kidney function long into end-stage kidney disease, and many studies have shown improved outcome. So the real, and everybody knows it's less expensive. So the real question is, why do we not have better penetration of home dialysis in the United States? And that's, I think, what we would like, ultimately, our panel to address. And so without further ado, well, actually, first what we'll do is we'll pose a couple of poll questions for the participants. So I'm afraid I can't read this. Oh yeah, this is good. In your practice, this is the first poll question. In your practice, what do you perceive to be the largest barrier to achieve the Advancing American Kidney Health Initiative goals of approximately 50% of dialysis patients utilizing a home therapy by 2025? And you can see the options there. Please select one. So it looks like the most popular response is 50% of my patients do not want to perform dialysis at home. And the next most popular is 50% of my patients are not able to perform dialysis at home. And I'm quite sure our panelists will have a lot to say about this, about both of those responses. I think we have another poll question, right, Steve? Right. So I'm having difficulty reading this one too until you pop up. There we go. The largest barrier to increasing home dialysis in my practice setting is, and you can see the options there. Don't forget to scroll down. So here it's really kind of a mixed bag. It looks like most people responded that CKD education needs to be improved so that more patients are aware of home therapies. But there's a close second, and that is that PD and home hemotechnology needs to become more user-friendly. So, so let's talk about, let's talk a little bit more about these options. So, you know, some people say that, that one of the big barriers is provider knowledge. That nephrologists are not knowledgeable about, not knowledgeable enough about home modalities, and that therefore they don't present these options carefully enough and thoroughly enough to their patients. Dr. Anamudu, do you have any thoughts about that?
Yeah, absolutely. Thank you so much. I think this is such an important part of the puzzle, and it really starts here. I would say that everything in our training programs is very much dedicated to in-center and so on. And I think that until our education really changes within our training programs, within our fellows, where they start really getting the practice of home modalities, how to educate patients, and get comfortable with it themselves, when they go out into practice, that is the only time that they will really start getting into this, unless they have mentors or advocates that are promoting this within their groups or within their programs. But I genuinely believe that provider education, at least in the US, is low in this topic, and it really needs to improve. And I think a lot of nephrologists may be uncomfortable with this, or they're comfortable, but they don't have that many patients. And so what seems easier is they'll just start with one modality, usually when they come into the hospital, and then transition them and then never look back. But I think it really starts within the training programs first with our fellows. And then also I encourage, you know, faculty who have been doing this for a while, or even in their own practice, to really go back and look at the basics and really take the time to educate all their patients on all the modalities. And until we promote it as a community and as providers, I think that's the only time your patients will really get into and believe that it's a good modality for them.
Yeah, thanks for that response. I know that all of you really have been very successful in growing home programs, and I wonder if you would like to talk about your experience in growing your programs and what really were the keys to success for you. Because I think a lot of people feel the barriers and need to understand how they can be overcome. So feel free, anybody.
I mean, I can start. So our program was actually, you know, people were doing it a little bit, but it wasn't a more concentrated program. And that's really been my direction in really getting this a focus within our fellowship program, but also within our providers, everybody on the same page. And I think the biggest part of that is we really needed a champion first, somebody to promote it, somebody to believe in it, and somebody to convince everybody. And so that's one of the biggest roles that I took, and really investing in the process. And then the other part with us is we really took a different direction and implemented it within our training program. So all the faculty, everybody is now involved in having the patients, in having fellows within our clinics, having the education available within the hospital, and having anybody who's being started being given the proper education, and kind of creating a system. And so for us, it was a kind of a revamping, re-educating, and then creating a nice outline process to get people properly educated and trying to grow our program.
Harry, I know you have a very big program. Can you talk about what your
Yes,
tests are?
I'll try not to get too long-winded, but this is like my one big question I wanted to tackle. So, PD and home referrals are all about workflow and bottlenecks. So we have about 220 patients in one of our biggest units. We have another small one of my partners works in. And subspecialization has been helpful. So I'm the one that does most of the care of those patients, along with my colleague that helps me some. So I agree completely with the physician champion model. Our old paradigm was slow and barrier laden, and the mental work a referring doctor in my group had to do to finally get a patient to be in a PD unit with a PD catheter was so hard. I often feel like people look at in-center referrals as, does the patient have a pulse? And even if it's erratic, it's fine to go and refer them in-center. But for PD, there's this giant Rube Goldberg algorithm, like 12 pages long before you'll go, okay, they're a PD candidate. So we had to break down a lot of those barriers, and it was slow. But let me just tell you a few keys that worked for us. First of all, we were in the back corner of our oldest unit in a place in town that was nowhere near any interstate. So right off the bat, it was just not anywhere close to most of our zip codes for our patients. So we built a new home unit, someplace that's just very inviting. You walk in, there's a fireplace, there's a coffee maker, it's less clinical. Right off the bat, you can send patients there before they even start on home dialysis, just to give them a sense of ease and let them envision what their life would be like on the intake. The other thing is, again, we developed more openness in choosing patients. As I championed this and gave feedback to my colleagues on the patients that they were referring, it opened their minds up to sending more and more people, including a lady with metastatic breast cancer who made it 4 years on PD with me. So those kinds of stories help build confidence in referrals. The other thing we did, and this may not be what you need to do, but we moved away from buried catheters. So no longer do you have to think about the timing. You just have a patient, they need to start PD, you just send them to get a PD catheter, and they start on PD. If they need to start immediately, well, you can call the surgeon, they'll work them in. We do surgeons put our catheters in. There's lots of good models for that. And then the final thing is we started Urgent Start in 2008. Huge, huge. We used to tell people, wait a minute, you can't send this patient to us, we're too busy. Send them in center for a couple of weeks. Oh my God, you'll never get that patient back. So we started Urgent Start, and that's when really the workflow of referring somebody was almost as easy as going in center. And that really took away the work and the burden of, then you could maybe spend just a little time selling home therapy and self-care to the patient. That's a little easier than doing all of the workflow and thinking about how do I get that patient to finally show up to the unit.
Harry, can you talk a little bit more about Urgent Start and what kind of staffing was required to put that into place?
Yeah, so that was my next point. So if you're going to do this and tell your nurses and your team to take people immediately, you've got to stay ahead of the game and hire more people. You've got to think about ratios and staffing. You've got to watch their back. You cannot ask them to work this hard at the drop of a hat to take somebody immediately. And so you never have to tell your partners, no, we can't take them. You've got to get warm bodies that are really good and trained, and you've got to get them there. That's a huge part of doing that. We don't make Urgent Start hard, and I'll wrap this up. Urgent Start's easy for us. Look, they're just a PD patient starting on PD. It just so happens that we don't put huge volumes in them initially. We do start most of our patients on the cycler. We don't do them all, but we start most of them on the cycler. We'll flip them to CAPD. They have a lot of residual, and it looks like it might work for them. But we just don't overthink Urgent Start. It doesn't have to be complicated. We don't have a lot of catheter leaks. And ultimately, these are just PD patients starting without having to wait for 2 weeks for no reason. And that's how we've grown our program. And I think, look at your elements in your program. And if any of these things you're not doing, but you think they might help you, I really want you to think about implementing some of these kinds of techniques. But our path doesn't have to be yours, but we really had to revamp everything that we did from the ground up. Thank you.
Yeah, thanks a lot, Harry. So it sounds like one of the ways that you've done this is just to sort of open your mind to eligibility. But are there any sort of strict limitations to who might be able to do PD?
Well, I mean, ultimately, we've had a few issues with vision. I know some people have had people with severe vision issues do home therapies, and I've always been interested in those success stories. It's been a little bit of a struggle for us. You have to have a caregiver if the patient is completely unable to do this. I mean, there are some things, but I think we focus too much on the long list of barriers to doing self-care, and we don't think at all about putting people in center. And I'm not telling you to be so open-minded that you create a bunch of disasters for PD starts, but I think we put too much emphasis on, and we wind up cherry picking too many people for PD. And that's kind of been, my approach is to be more open. And I've been amazed at the amount of people that could do peritoneal dialysis as well. And they don't have to do it for 8 years. It can be a modality as part of their pathway to either getting transplanted, switching to home hemo, whatever that path needs to be.
Mm-hmm. I know that the patient and caregiver anxiety is a big feature here. How do you surmount that? Arvind, I know you have some thoughts about this.
Right. So first, when we start patients on dialysis, especially the home dialysis, I learned from my partner that we give them a very simple example that, do you remember holding your baby for the very first time? And they say, yes, I remember, and I was scared. And that gives a segue that it's the similar to that sooner or later, it becomes a response that you don't even think about it. And we reassure them that we will train you, we will walk you along the way until you say that I am trained enough, I think I can do it. And I think it's very important to have realistic expectations for the patient so that there is no disappointment later that this was not mentioned or brought up to them as to what they expect when they go home, be it what is the time commitment, the dietary restrictions, or for that matter, relaxations for the patients who are in center. In our program, we actually do try to match patients with other patients who are doing home dialysis because I can tell patients anything and everything, but I cannot be 100% gain the confidence because I'm not in their shoes or I'm not going to. So hearing or coming back from a patient makes a huge difference for the patients to earn their confidence and for them to be comfortable. So we try to match the patients with other patients, especially for the de novo patients starting brand new, and have them hear it from the in-center patients who transition, and they can speak volumes than what you can spend all the time. So I think that's a bigger thing for the patients and the caregivers' anxiety. In addition, I think it's very important for the patients or the caregivers to know that we do implement respite programs, at least in our dialysis unit, so that if there's any problem, they can always come in and dialyze with us. Having them know that we do have nurses available 24/7. There are, if there's equipment failure, there's always a person on call from the company. That gives them a peace of mind. But having all those anxieties ruled out actually makes your path easier before they actually start training for dialysis.
So how important, Samaya, how important do you think the Medicare kidney disease education benefit is in having patients make a rational decision about modality?
Yeah, I mean, I think it certainly is important. I think any kind of education and investing in that time on the front end is essential. I mean, I think that's what it just comes down to. And for everybody to kind of invest in that and take the time to actually participate, and for patients to learn from it will be important. And then just to kind of add to what Dr. Garg was saying, I think staffing is huge, and having that support staff, that dedicated staff, we really help solve a lot of the issues with patients who even have urgent started, and they just need to know that they have the support. And if you don't have good staffing, then it tends to be a barrier for sure.
So is there a shortage of excellent PD nurses these days?
In my area, certainly, yeah.
Go ahead.
Oh no, yeah, and we have a shortage, and it may not just be as much of a shortage, but we have a lot of turnover, and so each company, or whoever it is, it tends to move nurses around. They'll be back and forth between 2 different clinics, And as the load piles up, they get burnt out. And that's honestly the more realistic view of it. And until you can really just invest and convince people to keep the staff on, and the numbers will come, but oftentimes they're stretched pretty thin.
Brent, do you have a sense of what the national scene is around PD nursing?
Around peritoneal dialysis nursing?
Yes.
Well, I mean, dialysis in general and home dialysis in general, we have a problem because the nursing staff is aging. And then we have a nursing shortage beyond just dialysis in general. And if you look at what we need to achieve for the Advancing American Kidney Health Initiative, we're going to need to add a huge number of home dialysis nurses. So I have concerns.
And I will also add that I have actually overheard our in-center nurses talking amongst themselves since the American Kidney Health Initiative that they better start training on for home dialysis because soon they may not have a job. So now how does it practically apply? That's a different story. So.
Yeah, we've noticed the same thing in our area. We've grown our own PD program by 50% this year, just this year. And we don't have the nursing staff to adequately serve that population at this point. We're rapidly training. So let's look down the line a bit, and maybe we don't have to look down the line. Let's say we grow the home population, PD population, and of course, as we grow it, those patients are going to require hospitalization, some of them. Are our hospitals able to take care of those folks adequately in your experience?
So in my opinion, there was some lag that we have to coordinate with our hospital unit, especially our outpatient dialysis unit is Fresenius, but the hospital unit was ran by the hospital itself. But we were able to get past those limitations by having our dialysis unit staff get access to the hospital EMR so that they can coordinate the care. In a sense, if patient has peritonitis, then they can know what organism it was. And especially when it comes to the discharge planning, we did have to work with them to get the PD catheters in place because the surgeons were not able to get the line in and or the catheter. And also, they did not have an urgent start program, but we came up with the protocols to be able to have the comfort level with those nurses, understanding that our outpatient dialysis unit are available all the time. The big barrier we have also seen is that let's say it's my patient who gets admitted to hospital, but my partner is on call, and they may not have the full detail of their peritoneal dialysis therapy available. So the ways we have come across is that the EMR we have through Fresenius is also available on the iPhones now, so that the physician or the on-call provider should be able to pull up the exact prescription and make sure that the patients get adequate dialysis. Obviously, backup is coordinating with outpatient dialysis unit. The orders get faxed. And we do a lot of buttonholes, which has been always a concern for us in the patients and their caretakers' mind, that they go to hospital, they're going to put a sharp needles, and that will create a problem from the access standpoint. But we coordinate with hospitals. We give them a one-on-one order that if the caretaker is there, we are more than comfortable letting the caretaker place the buttonhole needles for the patient, so that there is certain level of, I think, comfort level that also gives to the patients and their family members that the same therapy is to be continued. There are other barriers that one of the hospitals don't carry extra needle, and we do not use it on outpatient, but it's just making the patients tell that, hey, by the way, we are overseeing all this, and I reassure you that everything will be taken care of. So I think it's just more of I should say overcoming those barriers or the disconnect that has helped us coordinate the care.
Yeah, thanks. Do you think that there are any legislative or policy barriers to the kind of implementation of home modalities that at least the executive branch is interested in implementing?
I think, I think the Advancing American Kidney Health Initiative probably addresses most of those. So I would say yes. In the past, the concern that the reimbursement for managing home patients is less than managing in-center patients was a concern. That should go away if the initiative, especially the mandatory model, comes to fruition. I think the kind of what we perceived as onerous regulations around telehealth for home patients, with COVID coming and with the exceptions, I think that's been kind of taken care of and hopefully will continue. I'm the oldest one on the panel here, and so I'll comment. When I was a fellow, we only saw our PD patients every 3 months, unless they had problems. A stable PD patient came to clinic once every 3 months. And that didn't change until the regulatory changes changed. And so I think those are the sorts of things that'll help. But I would have to say that the executive order shows a lot of promise in getting over those regulatory changes. And then I think the FDA has been much more forward thinking in the last 3 or 4 years about getting technology out to the patients also. And I'll stop there. I don't know if the other panelists have any other comments.
Well, if I could just follow up on that, though, what do you think of the technological advances that have made life easier for the patients?
So, I think they're coming. I think that's one of the things that has frustrated me is in my career is that we've made numerous advances on the in-center and acute dialysis front, and home has tended to lag. And so we're starting to get there. And I think the connected PD machines and the fact that home hemodialysis machines have an internet connection, so the machine data can go out to the cloud and the nurses and doctors can pull it down. I think those sorts of things, continued making them smaller, easier, online fluid preparation, whether it's for dialysis on peritoneal dialysis or dialysis on hemodialysis, these sorts of things. I think continued ease, the GUIs, the graphical user interfaces on the machine is a big deal. Things like that. I don't know what do the other panelists think, because there's a bunch more that I'm leaving out, but that's what comes to the top of my head.
I completely agree with you, Brent. I absolutely completely agree with you. I think remote patient monitoring, there's continues to have stuff come out even this spring showing the benefit of that, and patient engagement with their portal. Being able to look at that data is helpful. But I completely agree with you. We need technology that's easier to use, and I'd love technology that overcomes some of the visual barriers for patients that can't see well. There's just a whole series of technological issues that would make machines easier to use, more reliable, more robust, and have less of an impact in the patient's space at home.
And then, like, for example, even in training, so we are piloting, POCUS, point of care ultrasound. So we are using some of these smaller, less expensive handheld ultrasound devices that can connect to a tablet to kind of show patients as they're learning self-cannulation, here's where you stick, here's the angle you go in. And as the population that grew up on video games starts to age, putting a needle in your dialysis access yourself becomes more like a video game and less of a blind chore. So just things like that, I think, will help us.
That's great. So one other question I had before we go to the Q&A, open up the Q&A, is about retention of patients in home programs. I know that's a big issue. The attrition rate of patients in home programs is a big issue. What do you do to keep patients at home?
Harry, you want to take that first? You have the largest program.
Yeah, so we struggle with this. Remote patient monitoring has been shown to help patient retention. Another thing that we did is we struggled so much with our PD catheter placement, and the exit sites were disasters. They're like little bombs that went off in the patient's abdomen, and they would get infected and catheters would flip. And so we brought someone down from Toronto, Dr. Todd Pinner, our surgeon. He talked to our surgeons in one night and radically reduced our complication rate. I'm telling you, we literally just paid for a steak dinner and paid for him to come down. And that was huge in patient retention. There's a whole series of other things you need to do. Programs that are larger, that train more often, have higher rates of retention because we think probably they get better education and there are more robust pathways to prevent peritonitis and deal with those patients. So I think bigger is better as we grow our programs and we get more nursing expertise shared within that program, even beyond what the doctor's doing. So those are some of the things I think that will help, and I would love to hear my colleagues' comment as well.
So I would say that first of all, we have to accept that attrition will happen. Not only our dialysis patient is high risk anyways, but many a times, like as we were trying to grow the program, we would take on patients who would be considered high risk out of the program. So we had to take it with a grain of salt that it would happen. Especially when you're growing a young program, you add 2 patients and you lose 1 and you go home. I was like, man, it was so hard, and here we are. So the first thing I would say is we have to accept that it will happen. But one of the things that our clinic manager has a policy of doing is root cause analysis, is that every time we do lose a patient, that go back, take a step back. What did we miss here? What did we forget here? To Dr. Miller's point is that just because patient had intact vision today may not mean it will be the same in 6 months, 12 months. And we as providers should be smart enough to know what's changing in their health, in their family situation, or did they lose anybody in the family who was their caretaker? And being proactive, especially for PD, you see the kinetics going down, the urine output going down. We have to be cognizant of the fact that PD is going to be limited, that we should be able to place AV fistula, and we have had significant amount of success, patients transitioning just from PD to home hemo. So that is still an attrition from the PD therapy, but it can help us retain the home dialysis therapy. So those are the things that we think of.
And I agree, Arvind. I think what you made a really important point that I just want to reemphasize to everyone on the call is the root cause analysis and where you have to push back. And this is something we don't teach. To Samaya's point, is even though we're getting to teaching the physiology of home dialysis better, we're still not teaching the practical aspects better, is when you get out in practice and you're the medical director of a home program, you have to push your quality meetings away from just the quip and towards the things that Arvind's talking about, like why did we lose that patient? How many patients have we lost? Why are our catheters not working? Would Harry talk? What are we going to do about that? Because your program is going to improve less on improving the quip than improving those sorts of things. So I think you made a really important point, Arvind.
Yeah, excellent.
Yeah, absolutely. I agree with all that. And I can tell you that having surgeon is huge. Having a good surgeon who you trust, who listens to you when you tell them where you want the site and what's better for the patient is essential. That was one of the biggest obstacles. We have different pavilions, and so we had to essentially, from the county, the uninsured had to also educate surgeons. If you put this in, they're going to essentially qualify, you will get paid. A lot of this was background education, but really having the buy-in from surgeons to put in good sites, but then also if there's issues, being able to bring them back in very quickly. And the other thing I would like to add is home modality is all about patients, but also their caregivers. I think if you really involve the caregivers, like one of our things is always, not really in COVID, they can't bring their loved ones in, but whoever's really helping them is right there with them. And they are often the reinforcers that, yes, this is work, or maybe you just had an infection this time, but let's see what we can improve. And a lot of that reinforces and keeps them retained and in it, because if everybody in the house buys in, that helps all together. But if somebody's nervous about it and you don't address those concerns, it'll happen. I have a young patient who I've talked to PD, he's convinced, but his wife had some family members who did not do well on PD and has essentially convinced him not to do peritoneal dialysis. And I had to go back, educate the wife, bring them into the clinic, show them around. And this is an ongoing issue because the wife said, no, just do hemo. And the husband was like, okay, that's it. But he's young, he's 35 years old, and he works. So there's a lot of investment that you have to put in, but really getting the caregivers involved and having their buy-in, I think is really important for retention as well.
That's great. I want to make sure that we leave a little bit of time for questions. We only have a few minutes left. Amy, do we have any questions?
We do have a few questions, and I see that Dr. Miller has answered a few of them by written, so if you've submitted a question, make sure you check back to see if there's a written answer in there. But let's start with, would any of you like to share your thoughts on incremental PD?
That's kind of all we do. We start people out low, and then we see what they need. We use a lot of diuretics. But pharmacists freak out over 240 BID of Lasix. But yeah, so I mean, that's all we do is incremental PD. We slowly raise it up to meet what they need as their residual goes down over time. If they start with a creatinine clearance of 9.6, that's a KTRV of 1.7. So that's something to think about when you're starting somebody with a fair amount of residual left.
Yeah, I agree. We do a lot of incremental.
Our next question is, what does one do with existing embedded catheters as one waits for CKD5 progression to begin PD initiation?
We
I don't do
PD.
embedded catheters. Yeah, I mean, we just could never get them to work. Down the road in Springfield, Missouri, they were able to. I mean, Harry, you had, for a while, you had it working, didn't you?
Not embedded catheters, no.
Oh, okay.
Hey, we don't do them. And what data we do have, which is not robust, shows that they don't work as well as ready-to-use catheters, immediate-use catheters.
Yeah, I would say if you're going to do embedded catheters, find a surgeon who's really energetic about doing them. I have yet to find one in the areas that I've practiced, but I know people that have. So I think that's a discussion with your surgeon.
They need to put about 26 in, according to the data, to be competent per year.
Wow.
All right, our next question, we probably have time for this one or maybe one after this. Will we ever get away from urea kinetic modeling in PD? We lose patients from PD with a KT over V of 1.6, despite the fact that they feel great. The PD nurses are trained and receive bonuses based on meeting somewhat irrelevant targets.
Yeah, I mean, Gary, that's a great question. And, you know, I think this is an area where the RPA can really helpfully be active. And also in some of the ASN committees and so forth, when we interact with CMS, that we don't get stuck in urea clearance and we start talking about patients, because I agree with you. I think it's a problem that we define how a patient is doing by urea clearance. And I think that's going to be advocacy. So days like today, hopefully people will start to make that argument.
Completely agree.
Great. Okay, well, I thank our excellent panelists. I hope all the attendees found this as enlightening as I did. And stay tuned for the next session. Thank you so much.